and good morning, everyone, and welcome to the October PQA Quality Forum Webinar. My name is Amanda Ryan. I'm Director of Education here at PQA. Today's topic is Forging Patient Connections, How Evidence-Based Technologies Are Expanding Access and Adherence. And as we do with every quality forum, I would like to review a few housekeeping items before we get started. First, please submit your questions during the presentation using the Q&A feature that's located at the bottom of your screen in Zoom. We will have a panel discussion in the latter part of our presentation today, and I will include your questions in that discussion. Also, the webinar recording and the slide deck will be available to PQA members in the week following the presentation, and that will be in the member resources section of the PQA website. Additionally, the recording will be available on PQA's YouTube channel. And lastly, I would like to encourage everyone to please complete the quick 1-minute survey that will appear as soon as the webinar concludes today. PQA would like to thank PerformRx for being an educational sponsor of this quality forum. Thank you to PerformRx for your support of PQA today and throughout the year. You can learn more about PerformRx at performrx.com. Also, National Pharmacy Week is October 17th through the 23rd. PerformRx and PQA would like to wish everyone a happy Pharmacy Week. We recognize the vital role that pharmacists and pharmacy professionals have in patient care as part of the healthcare team in multiple settings. In today's webinar, you will hear an example of pharmacists collaborating with the healthcare team to forge patient connections and improve the quality of medication use. And with that, it is now my pleasure to introduce today's speakers. First with us is Maureen Hennessy. She serves as Senior Vice President and Director of Value Transformation at PRECISIONvalue, where she has led more than 500 quality, population health, and value-based care initiatives for Precision's clients. She is a nationally recognized expert on physical and behavioral health integration and has chaired the technical expert panel on physical and behavioral health integration for the National Quality Forum's Medicaid Innovation Accelerator Project. Sebastian Sager is also with us today. He is CEO at Amoca Health. He co-founded the company with several other adherence experts at Johns Hopkins in 2014. Amoca partners with health plans, health systems, employers, and public health departments across the country to support patients at every dose through a digital medication adherence program. He has led Amoca to become a leading platform for video directly observed therapy in the United States, with over 100 customers spanning the healthcare landscape. Also joining us today is Charmaine Rochester. She graduated from Howard University College of Pharmacy in 1996 with a PharmD, then pursued her residencies at the Medical University of South Carolina and the University of Mississippi Medical Center. She is a certified diabetes care and education specialist and board certified ambulatory care pharmacist. She is a professor and associate clinical director of the P3 eHealth Services at the University of Maryland School of Pharmacy. Next, we have with us Samita Mishra. She is the enterprise-wide population health informatics leader of Northwell Health, where she provides operational oversight to the various population health integration and operational digital transformation initiatives. She has 20 years of experience in change management and operations improvement in the healthcare industry. She has a PhD in medical informatics and a master's in healthcare administration from Johns Hopkins University and ASCI India. And finally, Yulia Kogan serves as the IT director in the population health informatics department at Northwell Health. She has nearly 20 years of experience in health information technology, and she leads her team in improving innovative outcomes through digital transformation. She began her career in health IT after serving as a communications officer at IDF and completing 2 master's degrees in Israel. She led the establishment of a national platform for remote disease management. I would like to thank all of you for being here with us today. And with that, I will turn the floor over to Maureen.
Thank you, Amanda, and thank you all for being here with us today. I'd like to begin by giving you a little context about the organization I represent, PRECISIONvalue. PRECISIONvalue is a full-service managed markets agency, and we, among our many offerings, we facilitate value-based collaborations on behalf of our life science clients, and we support them with their various population health, value-based care, and quality improvement initiatives. With Precision, we, for example, help our clients gain insights around various kinds of innovative collaborations to determine their interest in collaboration with their clients. We also provide them with market landscape information so that they understand what's happening in the quality, value-based care, population health landscape, and how it's impacting everyone throughout the healthcare ecosystem. We also can provide them and do provide them with tools to help them engage with various stakeholders, health plans, health systems, PBMs, organized providers, to improve and advance population health outcomes. And we also facilitate dialogue, and through various kinds of initiatives such as roundtables and white papers, we seek to advance the dialogue and advance improvement in the area of quality population health and value-based care. Next slide, please. So I've mentioned to you aggregation of insights and surveys, and we have a proprietary library of various kinds of insights that we gather throughout the year with our clients, for our clients, and also for the general public. And we have a number of surveys that are particular relevance to the topic we're talking about today. But in particular, we're going to talk about care management. And I'm going to share with you some information from a study that we did this summer. And we surveyed 30 respondents, and you can see that they represent health systems, health plans, PBMs, also oncology practices. Their disciplines were pharmacy, medical, population health, nursing, and quality. And all in all, they were access decision makers involved as KOLs in the care management field for about 150 million lives. Next slide, please. What we found in that survey was that 43% of the respondents indicated that engaging with patients for better medication adherence was either very or extremely challenging. And we found that about 77% of them, or 3/4, a little more than that, were engaging with patients and caregivers to support adherence. And they also provided proactive calls to patients and to their caregivers to share information and encouragement with adherence. We also found that about 3/4 were willing to receive, 73% were willing to receive care management tools, resources, and programs from pharmaceutical manufacturers to support medication adherence. However, despite these challenges and unmet needs, there were a number of evidence-based methods that were underutilized. Only around half, 53%, used analytics to identify patients who were likely to be non-adherent. 43% used technology to monitor adherence. And even less, and again, less than half, 40%, used motivational interviewing or shared decision-making to support adherence. Next slide, please. So, given this information, what this webinar is going to do today is, first of all, share some information about 3 evidence-based methodologies that are used to address medication adherence challenges. One are some behavioral methodologies, motivational interviewing, and shared decision-making. Another is video-enabled directly observed therapy, sometimes referred to as video DOT. And another is conversational artificial intelligence, sometimes referred to as AI, analytics, and remote monitoring. And we'll focus on what are some of the potential benefits that can be experienced through the use of these methodologies, what are some facilitators for using them, and what are some successful practices for their use among care teams. Next slide, please. So I'm going to share with you briefly some information about motivational interviewing, shared decision-making, and also where you can go to learn more about these methodologies. And to start, Both of these methodologies, motivational interviewing or MI and shared decision-making or SDM, are patient-centric methodologies aimed at respectfully engaging with patients to help them make some decisions and to make progress towards optimal outcomes. And with MI, what we're seeing is that it's more of a conversational method to identify patient values and motivators and potentially resolve any kind of ambivalence that an individual may have regarding making change. And so with motivational interviewing, for example, we might be trying to find out what's prompting the patient to change. So with a patient who maybe is smoking and would like to quit, I had one patient who said to me, you know, I really want to quit because I want to have the energy to chase after my grandchildren and I want to see them grow up. With shared decision making, we're really focusing on how would the individual like to change. So this is a decision making model driven by patient values, and it's made in decisions are made in collaboration with the clinician and their patient, and sometimes their families as well. And the goal is to facilitate a decision between or among clinically appropriate options, balancing risks and balancing expected outcomes against the patient's own personal preferences and values. And so in that kind of situation with my smoking cessation patient, for example, that conversation was more about how would you like to quit? And we discussed the benefits and the drawbacks for behavioral coaching, for using over-the-counter quit aids and prescription medications. In both cases, you see that there is an elicitation of patient values and goals. There's effective communication is required with the clinician, and information must be exchanged between the clinician and the patient. But one focuses on motivations, extrinsic and intrinsic, and the other focuses on the path forward among a number of different evidence-based kinds of options within the context of the patient's preferences and goals. Next slide, please. So having talked a little bit about the differences and the similarities, I'll briefly focus on the MI process in this slide, and in the next one, the shared decision-making process. If you look on the left, you'll see that there are various examples of conditions for which MI has been successfully used. One involves improving continuation of a specialty therapy for MS with favorable clinical and also financial results. Another example is improving adherence to ACE inhibitors and ARBs among non-adherent patients who also had comorbidities, diabetes and hypertension. And another example is addresses improving adherence to antiplatelet medications post-coronary stent placement among racial minorities. So those are just a few examples of ways that MI has been found to be helpful. In the next column, you see just a brief review of what MI is. It's a collaborative, empathic, conversational style. The goals and roles typically are patient engagement, medication adherence, and participation in wellness activities. The triple aim is the goal, better care, healthier people, and smarter spending. And the theories that are used are psycholinguistic theories, which essentially help to promote change talk, which is associated with change. If you look over on the right, you'll see a brief overview of what are the steps of MI, and they involve engaging the patient, focusing in on what it is they'd like to approach or change, evoking change talk, and then also working back with the patient to develop a plan for change. The 4 principles of MI include supporting self-efficacy. So the idea being believing that a patient can change and encouraging and supporting their ability to change. Rolling with resistance, so not arguing with the patient, but more expressing empathy, understanding that change for many times is difficult, and helping also through the development of discrepancy, identifying the ambivalence that a patient may have about change and helping them to work through some of those ambivalences that they may have that may be based on thoughts, maybe based on actual pragmatic obstacles. And then finally, just the 4 skills, core skills of MI. Ask open-ended questions to understand the patient's goals and their obstacles and their beliefs about change. Affirmation, affirming their capacity for change, and also affirming even small steps that are making progress in some way, reflecting back on the patient's thoughts and their concerns about change, and also summarizing, but particularly when summarizing, identify those areas of change talk or plan for change, and then use those as a bridge for future planning. Next slide, please. So let's talk a little bit about shared decision making. Again, there are a number of examples here to your left. Shared decision making has been used to improve adherence with anti-rheumatic and asthma therapies, and also to support patients' decisions regarding intensifying diabetes therapy. In the center, you see a very commonly used model, the 3-talk model of shared decision making. The first step being team talk, where you let a patient know that they have options and that their care team is there to support them in making some decisions in that regard. The second step is option talk, where the alternatives are discussed with the patient, with their risks, their potential benefits, and also within the context of the patient's values and their preferences. And many times a decision aid may be very helpful in structuring that conversation. And I'll share with you some resources for decision aids on the next slide. And then finally, the last step, it deals with actually decision talk, where the focus then is further elucidation of the patient's values and preferences, as well as any questions that they or sometimes their family members may have, and also with the goal of aligning the treatment decisions, evidence-based treatment decisions, with the patient's informed preferences. Next slide, please.
Hey, Maureen, just jumping in with a quick time check.
Sure, thank you. This is my last slide. Thanks. So just to wrap up, there's a great deal involved in gaining skills and familiarity to be comfortable and to be effective in using motivational interviewing and shared decision making. So I want to leave you today with a few resources that you can turn to if you'd like to learn more. And also I had mentioned the various kinds of patient decision aids. The Ottawa Hospital's website can help you with that. And AHRQ, of course, has a whole module for training in shared decision making. So with that, I'm going to turn this over to my colleague, Sebastian Sager from EMOCA, and they will talk with you about their visual direct DOT, as well as how they integrate motivational interviewing into that process. Thank you.
Thank you very much, Dr. Hennessy. I'm Sebastian Sager. I'm the CEO of EMOCA Health. Our mission is to help every patient take every single dose of their medication. And so when I speak about adherence today, I'm talking about the extent to which patients take their medication properly, as opposed to adherence as a measure of refill. And I'm joined today by Dr. Charmaine Rochester from the University of Maryland, who you'll hear from in a couple minutes. Next slide, please. So we have more than 120 customers right now. We've validated the approach of a video directly observed therapy adherence program in 12 peer-reviewed studies, the last one coming out 2 weeks ago in the Journal of Asthma. We spun out of Johns Hopkins, and our mission is to create a world where taking all of your medication the right way is a cultural norm. So like seatbelts today, seatbelts in the 1980s, when I grew up, they were kind of optional, right? My parents just threw me in the back of the car. Not today. Now my 4-year-old tells me to put my seatbelt on. And so it will be with medication as well eventually. Next slide, please. Medication adherence is a very complicated issue. It's complicated at the patient level and at the individual patient level. We know about the behavioral challenges, people forgetting that's just the surface. Medication challenges, that's where really the hard work and the blocking and tackling happens. Asthma inhaler technique, for example, complexity of dosing regimens, side effects that are experienced. These are all things that stop a patient and lead to more than $350 billion per year in preventable hospitalizations. Next slide, please. So there is one solution, and this is if you scan literature, this is the very best solution that's been tried so far. It's 50 years old. It's called directly observed therapy. It's when a healthcare worker or a pharmacist or a nurse sits with a patient and makes sure that they take every dose of medication and monitors their health, side effects, et cetera. It's the standard of care for every single dose of medication dispensed in every single hospital to every single patient in the United States of America. Outpatient, it's the standard of care for very high risk situations because obviously this is a very hard standard to implement. It's very burdensome for the patient to meet every day, and of course, not affordable. In 2014, we decided we were going to use technology to scale this process. Next slide, please. So we've created a digital medication adherence program that uses asynchronous video, so video recordings, and real human beings, real clinicians, to scale directly observed therapy. I cannot underemphasize the fact that technology alone will not solve the medication adherence challenge, but engagement from pharmacists, from nurses, adherence coaches, and beyond. So there are more people in the care continuum than just these three, can solve the problem. And we have taken this directly observed therapy gold standard and just transitioned it using technology. Next slide, please. The pharmacist is very, very important because we cannot monitor medication adherence on a daily basis unless we are very clear as to what the regimen is and the patient understands what their regimen is as well. So we start with a comprehensive medication review, then we do 30 to 90 days of directly observed therapy. We do provide financial incentives along the way, very small ones. And then thereafter, we engage with the patient to check in. We monitor refill data. We do then track possession metrics. And this is remote therapeutic monitoring. What is RTM? You will hear about that from Dr. Mishra and Yulia Kogan in a couple minutes, so I won't spoil that. Next slide, please. And just to drive home the point that by increasing possession, you might improve real adherence, whether patients take their medication. But if you absolutely master true medication adherence on a dose-by-dose basis, you can for sure improve the possession of medication. And I think that over the next few years, there will be alternative methods for measuring medication adherence besides the possession metrics. I would like to turn it over to Dr. Rochester to explain an amazing implementation we had the first time we integrated pharmacists into the EMOCA digital medication adherence program. So with that, next slide, please. Dr. Rochester.
Thank you, Sebastian. Well, in addition to the video directly observed therapy, the pharmacists met one-on-one with each patient via teleconferencing to do a comprehensive medication review. This review used open-ended questions and also motivational interviewing in order to investigate if there were any medication-related challenges or barriers or concerns that the patient may have. The comprehensive review looked at not only the asthma medications, but also all of their herbal, over-the-counter, alternative therapies, as well as their prescription medications to unearth any problem that the patient may have. This gives us really direct information. While looking at the videos, we were able to look at the patient medication adherence and also their asthma inhaler techniques. At the end of the comprehensive review, each primary care provider received a very detailed report of all of the problems and challenges that were identified, as well as recommendations based on updated clinical practice guidelines. The patients also received a summary report of all of the problems identified and also recommendations as we discussed during that teleconference. We were able to also inform the members of the video direct observed therapy portion of the program if there were any technical challenges. Next slide. While observing the video virtually directed observed therapy, we noted that every single patient had a medication-related problem. This gives us a lot of insight into what is happening at home. So we were able to provide very specific counseling. Based on a very small pilot, we noted that each patient had an average of at least 4 medication-related problems, most of which related to poor asthma inhaler techniques. So they were not able to get the benefit of the therapy. In addition, they didn't really understand the reasons or purposes of each medication. There was also problems with their asthma control because they needed additional therapy to control and prevent an asthma attack. So those recommendations were forwarded to their providers. 10% of the patients were overusing their albuterol inhaler, which is really just a rescue inhaler, but they were using it around the clock because of increased symptoms. In several cases, we noted that patients were using both generic and brand name medications at the same time because they lacked the knowledge of those medication names. So the direct observed therapy allowed us to be able to identify very specific issues and techniques and correct it while we were doing a comprehensive review at the point with the patient. Next slide. At this time, I will be moving back to Sebastian.
Thank you, Dr. Rochester. So a couple weeks ago, this publication, this is work we did with LifeBridge Health in Baltimore. The first pilot, that effort is now continuing and is becoming standard of care at LifeBridge Health in Baltimore. And this was published 2 weeks ago in the Journal of Asthma. So these are really interesting statistics and show the value of having a human and technology approach. 81% of patients that were eligible enrolled. The program was launched via the provider. So sometimes with health plans, we call out to patients, we reach out to them, but we found that when implementing via the provider, whether it's the nursing team or the pharmacy team or the actual physician, the enrollment rates are excellent. Within the first week, we did realize that there were technique issues with the inhaler. This is all kids, by the way, in about 3 out of 4 patients. And that's a really interesting problem that, you know, in Baltimore, probably you could isolate asthma ED visits to basically 2 neighborhoods in the inner city. And it's really alarming that these children go home and don't really understand how to use the inhaler. By the second week, those issues had resolved. So this study shows that you can resolve, using directly observed therapy, you can resolve inhaler technique issues within a couple weeks, and that those errors are very, very prevalent. So in other cases, we've also shown that directly observed therapy can lead to hepatitis C cure. We've shown that we are comparable to directly observed therapy in tuberculosis, where we serve hundreds of health departments. So the value of medication adherence support and monitoring, it's different for every type of population. But very interesting is that there is tremendous benefit in helping patients at every single dose. So with that, I'd like to thank PerformRx and PQA for having us today. And I will turn this over to Dr. Mishra and Yulia Kogan from Northwell.
Thank you, Sebastian, and good afternoon, everyone. I would like to begin by giving you all a bit of a context about our organization, Northwell Health, and then myself and my colleague, Yulia, will dive into some of our innovative ways to leverage technology to improve the lives of the populations we serve. So we are essentially an IDN with a large footprint in Greater New York region. We do have some presence in Florida, Connecticut, Vermont, but we are predominantly in New York. We are more than just a health system. We have 24 tertiary care hospitals and an academic affiliation. We also have a research institute called Feinstein. We have a large IPA and close to 1,000 ambulatory care physician practices. We see approximately 2 million patients a year with maybe about 500,000 encounters a year. So talking about scale, we do have a big scale. We have more than 70,000 employees, and we are the largest private employer in New York region. So I'll not go through the entire slide and the stats, but I will let you glance through them. so that you can understand the breadth and scope of our organization. I do take pride in saying, as the population health leader, that we are a progressive organization when it comes to adoption of innovative ways to improve the lives of the communities we serve, and in embracing the concepts of population health, total health management, and all that good stuff. We were at the epicenter of the COVID surge in New York in last March. And the volume and the acuity of the patients we saw was unfathomable, right? It was unimaginable amount of stress on our existing health systems and on all our systems in general. And remember, this was not what it is today. This was more than a year ago. We did not know the virus. We did not know the level of risk. We just knew that it was deathly. The treatments were untested. Our EDs and our ICUs were overloaded. So our communities were in crisis and shutdowns were being implemented. It was a time of fear. It was a time of anxiety, uncertainties. Guidelines were changing by the hour. And the unprecedented nature of the COVID pandemic caused our organization to evolve, to adapt, and innovate very rapidly. Data and technology were the key components that really helped us to meet the challenges, and population health was at the center of keeping the various efforts aligned and coordinated, not to discount how much interoperability went in there among every single service line. So this is a good segue for us to move on to our next slide. If I can have the next slide, please. Thank you. I would like to really talk about chatbots as part of our COVID management strategy. The pandemic saw an unprecedented volume of calls to our call center, which required innovative approaches. We did not have any other choice but to think ahead of the virus, right? We deployed interactive chatbots, which was implemented to triage the heavy call volume. The chatbots were also used to deliver COVID test results in near real time and to monitor the recently discharged patients. We had already implemented Northwell Health chats for several populations and disease management programs, like transitional care management for high-risk patients during a post-discharge window, radiation oncology division. Our community investment team had deployed it for colonoscopy screening. So the infrastructure was somewhat available. The initiatives in silos were successful, but the approach was very siloed, and it was now the time to act with what we already had that we could leverage. So last March, we quickly identified 2 use cases for the chat. First was our emergency operations team was calling patients with COVID test results, and even negative test results were often resulting in lengthy calls with too many questions. And that was reasonable, but we had to do something about it, and quickly evident that a system of phone call was not going to be scalable for the amount of testing we were doing. And so we implemented the use of chats to deliver COVID test results. Patients provided a phone number and an email, and when the lab results were available, a message was sent through a secure link to view their lab results and also to request a copy of their medical records for their own records. And the fact that we also included literacy about COVID and updated information, allowing us to share the most current information while only having to update it in a single place, was cherry on top. And for the second use case, we had COVID positive patients being discharged from our acute care facilities as soon as they were stable enough to be managed at home, because it's not like we had beds to spare. These patients were enrolled in our rapid transition program, where they were provided a pulse oximeter, discharged home with supervision from a care navigator, mostly nurses, nurse practitioners, etc., and the use of chats to report their system and other needs every day. A study was conducted between April and July of 2020. Chatbots were used for those two use cases, and we actually had over 18,000 patients that were enrolled in that program, and with more than 350,000 lab results delivered via chats. And the best part was that the data shows high utilization, and that patients found it helpful or somewhat helpful. And there was a 98% patient satisfaction rate. And there were more than, and I have to read because some of these metrics I'm extremely proud of. There are 278 COVID-19 monitored for up to 2 weeks following discharge. There were patients provided about 5,000 responses to daily questions about systems and social needs to prevent unnecessary in-person visits, and responses monitored by RNs were escalated for additional interventions as needed. Hence, definitely a great example of leveraging technology to improve and scale healthcare outcomes. With that, I will hand it over to Yulia to speak to some of our other initiatives around remote therapeutic monitoring, medication adherence, and last but not the least, our evaluation program, which is to keep checks and balances on the value of investment as we go full speed on digital innovation, because when you are focused too much on strategy and innovation, you lose track of the efficacy of the programs, which we did not want. We did not want to make that rookie mistake. So, Yulia, take it on.
Thank you, Dr. Mishra. And hi, everybody. So just to kind of make the connection to the medication adherence programs, while the focus can be around the specific program, we as Northwell also focusing on scalability. As Dr. Mishra mentioned before, we are a large health delivery system in the New York State region. We do own pharmacist chain and many outpatient clinics and about 23 hospitals. So kind of our goal was, how do we not just create the digitally based medication adherence programs, but also scale these programs? And I think, the Emoco CEO just mentioned it earlier, some things are becoming to be habits at some point. You go into your car and you put your belt on and it's by default, you just remember that. That's what we are focusing in this specific presentation is, how would we make the medication adherence program to almost like a blueprint that will eventually become something that is integrated in the care delivery. And the first question is always, yes, what's the technology? Hence, Dr. Mishra, that's not necessarily the first question, it's one of the questions. Hence, Dr. Mishra was reviewing the technology that during the COVID time, where we needed to quickly respond to the need of providing care to growing need, we scaled it by introducing artificial intelligence-based conversational technology. And this is something that we are also looking to utilize for medication adherence blueprints as we are creating it. The other component of this equation is, how do we scale it from the billing perspective? While we can do a lot of pilots in parallel, if we scale, it has to be also viable from the financial perspective. So with RPM codes, I don't know if anybody listening here are familiar well with this code, so I will just mention in few words. RPM codes are remote physiological monitoring codes that are being reimbursed today by CMS, and these codes are being reimbursed based on the monitoring activities in enrollment activities, and also any clinical follow-up that needs to be done with the patients because of the monitoring outcomes. For example, we have a blood pressure devices with hypertensive patients, and that patient is kind of trending up, and we have a care management team involved. They see that it's trending up. They may need to call the patient. They may need to call a provider, involve the care team. All of that work also needs to be financed somehow. And that is done through the RPM codes. With medication adherence program, the RPM codes can work, but it's a little bit more challenging. And the major reason is the RPM requirement is that the medical devices are actually transmitting the data directly to our servers. So from technological perspective, we cannot rely on patient-reported data, and that kind of creates some challenges to scalability. Northwell participated very heavily with CMS creating and working on the 2022 codes, and you can see the codes on the screen now that will serve for the billing purposes for programs that are not requiring this automated submission. And in this program, we can really scale and create the bigger blueprint for RTN program. So if we go to the next slide, please. It's really what I kind of presented at this point is really how do we take this conversational AI technology, merge it together with the ability to finance this program and utilize the changes to proposed RTM rules, and we create more scalable medication adherence programs that will eventually become the blueprint that we're hoping for. And if you can go to the next slide, please. The next thing is, yes, one thing, having everything there, setting our success processes, but we also want to take the smaller steps toward the bigger success. And each time we want to evaluate the success. So we had developed the rapid cycle evaluation program, which relies on the learning health system, HRQ kind of guidance in general, where we do identify the projects that require such an approach and require constant evaluation. Our evaluations are 90-day cycle-based evaluations. We assemble a team for each evaluation. We identify the success metrics. We analyze the data, make recommendations, and then we publish within the health system, we publish the evaluation reports and go so on and so on. So this system really, what it does help us is to not just create the blueprints, but as we are creating it in a rapid way, evaluating that the programs are scalable and going in the right direction, and make adjustments almost like the same way as within IT, we have the agile approach versus waterfall approach. This is where we're taking more agile approach. And if we go to the next slide, please. The entire learning health system approach is based on, as I mentioned, on HRQ, and it involves the service line representative, which is the practice. It could be the pharmacy representatives as well. It also involves researchers that are making sure that the evaluation is thorough. We're working very closely with the Feinstein Institute in Northwell and specifically Center for Health Innovations and Outcome Research, and it involves data, which is our team, the informatics team. And if we go to the next slide, with that, I would like to turn it back to Amanda, and happy to take any questions.
All right, Yulia, thanks to you and to the entire panel for sharing your work with us. We have time now for a question and answer discussion. I've seen several questions coming in through the Q&A. If you have additional questions, please enter those for us. We will work on answering those verbally for you here over the next couple of minutes. But for now, we got a couple of questions to get started with. I will address the first one here to Maureen. Maureen, you talked in your part of the presentation about motivational interviewing and shared decision making. Can you tell us if those tools have been used with vaccine hesitancy at all and what those results have been like?
Oh, interesting question. Thank you. Yeah, there actually have been some studies that have looked at vaccine acceptance and motivational interviewing with some potentially positive results. And in fact, both the CDC actually has some suggestions for the use of motivational interviewing with individuals who are having hesitancy with regard to vaccines. And also the World Health Organization has some resources that are focused more on vaccine acceptance in general, not just specific to COVID-19. So I'd refer you to those resources. With shared decision-making, there's been some research that's been positive around accepting influenza vaccines and getting vaccines for influenza. And there's some people who suggest combining MI or motivational interviewing with shared decision-making to help advance vaccine acceptance. Thanks.
Absolutely. Thank you for that, Maureen. Interesting that you can apply these tools to a lot of different things. So thanks for sharing that with us.
Sure.
Sebastian, next question I have is for you, and this is about why medication adherence. Why is that a great use case for the remote therapeutic monitoring codes that we were discussing earlier?
Yes. So first off, when first published by the AMA, the codes said therapeutic monitoring, and CMS specifically inserted adherence into that. So therapeutic adherence monitoring. So it's very, very clear that CMS has been hearing the commentary over the last 3 years on the RPM codes that medication adherence should be explicitly addressed. So I think medication adherence is a really tricky topic where solving it affects all sorts of different players. So it's one of those situations where you want to solve it for the patient, but the risk is split out to all these different stakeholders, and there's no incentive for any one party to take on the burden. So with RTM, remote therapeutic monitoring, you have this opportunity to finally address the problem. It's the first step only, though, because it is a fee-for-service approach. It's bizarre. It's a fee-for-service approach that's hitting at a value-based care initiative, which is like helping this patient take their medication properly. So I think with medication adherence, you have this opportunity to fix many, many different things by hitting the one endpoint.
All right, very good. Thank you, Sebastian. I'm going to jump over to Yulia for the next question here. Yulia, we've been talking about Pharmacist Week or Pharmacy Week and the role of pharmacists in the healthcare team. So this question is about pharmacists and whether they can do RPM and physiologic monitoring as a QHCP. If you could also define for the audience what a QHCP is, just as a reminder, I would appreciate that.
That's a very good question. I see, Sebastian, you're smiling as well. So, the final rule is not released yet. We are looking for seeing, the final numbers and everything in November. I had mentioned earlier that one of the things that changed with RTM, that this data for medical devices does not need to be transmitted automatically, but can be reported by patient. But the other thing also is that other than physicians, other clinicians can bill under the same codes. For example, we do have a physiotherapy program, which we couldn't bill under RPM, and we are looking forward billing under RTM. So it's definitely expands on the many other clinicians that can bill for it. So I wouldn't want to say, yes, pharmacists can, because we don't know what will be coming. But I think you guys should stay tuned and follow on this and see what will come. And again, the comments are open every year. So I definitely encourage everybody, as a person, as a personal thing or as an organizational thing. Once CMS open this comments period, which is usually runs around August, September, October, provide your comments. And as I think, Sebastian, you mentioned that they do listen, they do adjust, and we see how they work with us in adjusting this codes to be better serve fee-for-services for value-based delivering. So we're very happy and excited seeing that.
Well, we're on the edge of our seat to see how that turns out. Sebastian, did you have anything else you wanted to add to that?
No, I think Yulia Kogan got it exactly right. So the physical therapy is part of this code, and that's, while for us we haven't gone into that space, for a lot of other areas, I think it's going to be very helpful there.
All right, fantastic. Charmaine, I have a question for you, and this is about the pilots that you described for us that you've been working on. Were student pharmacists a part of that pilot at all? And if so, how did that work? And I'm just curious how you see this type of technology influencing the practice of student pharmacists throughout their career.
Yes, thank you. I had pharmacy technicians who were helping with the project more so than students. Students may have observed, but more so the pharmacy technicians help on the daily basis, reviewing the videos and looking for very specific problems. So they had a very defined area, but the pharmacists also looked at it and was able to respond in time if there were any major problems. But I do think students need to be involved also, and the few that were with us at the time were able to be involved with it. They were very excited, as they may realize this is part of the future in terms of addressing medication adherence, which Sebastian just mentioned is a very big problem. It's a huge problem and needs a lot of assistance from many different areas.
Yes, absolutely. Thank you, Charmaine. Appreciate that. Sumitra, I was wanting just to follow up about several of the comments you made about looking at conversational AI technologies, scaling, how to apply that to a lot of other different opportunities in addition to COVID-19 and what you've done so far. Where do you see conversational AI going next? Is it mostly related to medication adherence? Is there a completely different way you might see this used? I'm curious what the future of that looks like.
So that's a great question. I would say that definitely medication adherence is a great use case. Even while we were doing COVID or when we were doing the non-COVID use cases, medication adherence was always a part of it, right? Engaging the patient to be your design partner comes with the patient being compliant with what you ask them to do, and medication is a big part of it. So COVID-19, when our patients were discharged home, just because they were discharged doesn't take away our responsibility of making sure that they are not getting sicker and they are actually abiding by whatever the medications was, and they were taking it. What if they did not have the access to those medications? We would ask them that question using chatbot, and then we will make sure that we get that medication to their doorstep so that they're not stepping out and spreading the virus in the community, getting sicker or getting fatigued when they are not supposed to be out and about, right? So adherence was always there. But outside of medication adherence, I see the chatbot technology to really improve end-to-end population health management. I already mentioned a little bit about the transitional care management, the chronic care management, and all the other different non-COVID use cases that we are already deploying it for. I see that if it can be a standalone platform in itself. It definitely helps the patient feel more engaged. There is a little bit of lack of human touch there, but it's the closest to human touch that we can bring them to, while not depleting all our resources who would be all over the place, right? But at the same time, it can also supplement other programs like transitional care management through a hardcore care navigation team, or a AI ML program which is predicting the risk score associated with the likelihood of a patient ending up in a hospital. How do we as a health system prevent 30-day readmissions, prevent avoidable admission? And I see the chatbot really playing a tremendous role going forward in helping us with all those different use cases.
All right, very good. Thank you for that very comprehensive review of what we might expect. So thanks for answering that question. I'm going to circle back to Maureen now, related to shared decision-making and motivational interviewing. Just touch on that again. One, of course, common concern in healthcare is lack of time. And so sometimes we are a little bit apprehensive of certain tools if they take a long time to use. So can you tell me a little bit about shared decision-making and motivational interviewing and how much time that might take?
Yeah, sure, I'd be glad to. So from a motivational interviewing perspective, what the research suggests, and certainly what my own clinical experience has been, is that when you integrate motivational interviewing methodologies right into your contacts with a patient, your encounters with a patient, as opposed to, say, for example, just customary kind of advice giving, you can integrate that into, say, even as brief an encounter as a 15-minute encounter with positive outcomes. And potentially, it's often better to have multiple positive outcomes multiple outcomes to get positive results. From the SDM perspective, what some people, I've seen at least one large meta-analysis that looked at that issue, and they were saying about 2.6 additional minutes were absorbed by using a shared decision-making approach, but many people thought that that was really countered by the fact that the quality was substantially improved, in that patients felt very comfortable with their decisions as a result of the SDM interventions. And decision aids are very helpful in truncating that time.
Yeah, definitely having those tools available, I can see how that could make it more efficient. So thanks for that response, Maureen. I'm going to jump back to Yulia here. This probably will be our last question. So Yulia, you talked about AHRQ's learning health system model. I'm curious what advice you might have for other health systems who are interested in adopting that model. What kind of tips do you have to offer for them?
Invest in planning this model, and really the learning health system model is not just about understanding what works, what doesn't work. It's also about building the better team collaboration, assigning the right teams as well. We saw, as we are doing these evaluations, the added value of it is pretty much immediate. First of all, we speak more to each other, and that's already improves what's happening. The collaboration itself does the work. And then the second, as we identify the data issues, as we identify the impact issues, we are immediately sending the messages to other teams through the leads, because it's really a combined team. And then the implementation of improvements is happening at the same time, way before the report itself is released. So even if the report released within 3 months, we did one of the evaluations we did, it was telehealth adoption within older adults population. And we had some challenges within the workflow. And we saw the improvement coming kind of together with the release of our report, because we had on the team somebody from the telehealth department, and that person immediately went back and kind of the feedback happened. So things were happening very quickly. So planning this teams collaborations, planning the workflow of the evaluation program, I cannot say enough how much of the ROI there is there. And Dr. Mishra can really chime in here on this one as well. We had a lot of questions like, how is it sustainable? Because evaluation costs money, right? You still need to sustain it. And as one of the executives told us, what do you mean? Like, how can you not do that? Like, if you invest so much money in technology, don't you want to know what does it do for your populations and community? I don't think it's the right question even. So it's kind of something to think of. And my suggestion, first, do it. And second, plan it, invest in planning. Dr. Mishra, do you have anything to add?
Well, in the interest of time, maybe not, but one little nugget I would add is, you said, do it, plan it, but also evaluate it at the end, right? Because we don't want to keep on investing on something if it's not deriving ROI or VOI. So bad money after bad money, that's the concept that most often we fall into that booby trap, right? So we just need to continue to, that's why we thought that our organization introducing an evaluation platform to do something like this, to select for our select high value project makes much more sense, so that we can be agile.
All right, we have maybe 20 seconds left. Maureen, you have one last thing to add?
Yeah, I noticed that in the chat, someone had asked a question about training. And one of the things I really want to encourage is, when you're thinking about motivational interviewing, for example, look for individuals who have demonstrated expertise, either through their publications, their certifications, their licenses in the area of motivational interviewing. And my suggestion would be to get 2 to 3 days worth of solid training if you think this is something you'd like to do, and then get ongoing supervision or coaching in this area, because it's the kind of set of skills that if you integrate into your practice, it can be very effective, but it takes practice to get better and better at it. Thank you.
All right, thank you, Maureen. On that note, we are out of time. Thank you to all of our panelists for that great discussion. Really appreciate your input there. We will switch back over to the slide deck and I will run through a couple of upcoming opportunities we've got here at PQA. We do have our fourth quarter stakeholder advisory meeting that's going to be happening on October the 27th from 1 to 2 o'clock Eastern time. It is a members only staff hosted meeting. We will talk about measure development and maintenance updates along with engagement opportunities. The registration link is available on the member resources library section of the website, and we also have sent that via email. Also, we are less than 3 weeks away from the PQA Leadership Summit that is going to be on November 10th and the 11th in Arlington, Virginia. This year's summit will be a hands-on meeting where key leaders from PQA's member organizations will engage in a series of interactive discussions around Blueprint PQA 2025. We'll be talking about implementation, feasibility, and completeness of that plan, and we do look forward to seeing you there. I would also like to invite everyone to join us immediately before the Leadership Summit in Arlington, Virginia. We are hosting a special half-day workshop called Medication Use Quality, a PQA Live CE event. The event is ACPE accredited for 4 hours of continuing education for pharmacists. It is open both to Leadership Summit attendees and those who are not attending. It is open to people who are not pharmacists as well. Attendees will have the opportunity to interact with PQA staff and other quality professionals, and will learn about the role of quality measurement in healthcare and essential measurement concepts. Attendees will receive special discounts on PQA's online CE content as well. For more information, I'm going to drop a link in the chat as soon as we close here in just a moment. You can also contact us for additional information. I would also once again like to thank PerformRx for being an educational sponsor of today's Quality Forum, and special thanks to all of you in the audience for spending a bit of your pharmacy week with us. And then finally, our next Quality Forum webinar will be on Thursday, November the 18th. Pharmacy Quality Solutions will join us to talk about 2022 Medicare star ratings. And this particular Quality Forum is exclusive to PQA members. So registration information will be sent via email, and it will also be available on the member resources section of the PQA website. Thanks so much for joining us today, and have a great rest of your day.